Good evening, everyone. Thanks for joining us for our TIF Talk this evening. My name is Wendy Profit, and I am with Endogastric Solutions. With me this evening, I have my good friend Karen Girth, who will be manning questions. It is our distinct pleasure to welcome a doctor who really needs no introduction, but we're going to go ahead and give it our best. Dr. Kamran Ayub is with us from the Greater Chicago area. Good evening, Dr. Ayub.
Good evening, Wendy. Good evening, Karen. Thank you for having me as a guest.
Thanks for being here. Want to go ahead and share with our audience a couple of things before we get started. Number one, Dr. Ayub is here to answer your questions regarding GERD, and we will be doing so multiple times throughout the broadcast. So please go ahead and post your questions in the comments section. I'd like to go ahead and tell you a little bit about Dr. Ayub. He earned his medical degree from Khyber Medical College in Peshawar, Pakistan, and he completed his internal medicine residency at Greater Baltimore Medical Center, where he served as chief resident. His fellowship in Gastroenterology and Advanced Endoscopy was completed at Baylor College of Medicine in Houston. Dr. Ayub specializes in diseases of the pancreas, the bile duct, the esophagus, including gastroesophageal reflux and Barrett's esophagus, and cancers of the digestive tract. He has a passion for teaching, research, and innovation in the field of advanced interventional endoscopy, and he holds several patents for novel endoscopic technologies. Dr. Ayub has trained numerous doctors in advanced endoscopy and has written and spoken extensively on these topics at national and international meetings. He currently serves as the director of the Center for Advanced Endoscopy at Silver Cross Hospital. He is president of the Illinois Endoscopy Society and is medical director of Oak Lawn Endoscopy. He practices in Downers Grove, in New Lenox, Oak Lawn, and Joliet, Illinois, and has been performing the TIF procedure since 2009. Welcome, Dr. Ayub.
Thank you, Wendy, and thank you for the very generous and kind introduction.
It's my pleasure. Well, let's go ahead. Before we get started, I do want to ask, where are you broadcasting from this evening? We know you have multiple office locations, operate at multiple hospitals. Where are you today?
So today I'm in New Lenox, Illinois at Silver Cross Hospital. I go to 5 different hospitals, do special procedures only, including anti-reflux procedures. Silver Cross tends to be my main hub. And I'm the medical director here of Advanced Endoscopy Center as well. So Monday and Tuesday I'm here. And right now I'm at Silver Cross Hospital in the endoscopy lab.
Well, thank you. All right, so to kick things off, let's go ahead and, if we can, just ask you, what is GERD?
So GERD, or GERD, stands for gastroesophageal reflux disease. Gastroesophageal is somewhat of Latin and Greek terminology. Gastro stands for stomach, esophagus stands for the tube that transfers food from mouth to stomach. Gastroesophageal reflux disease is a rather common problem in this country. Gastroesophageal reflux disease, or GERD, occurs as a result of stomach acid coming back or regurgitating into the esophagus. Most of us, there's a junction between esophagus and stomach called gastroesophageal valve. Most of us have a normal or tight valve. It is like a sphincter that stays closed, opens only when the food bolus passes from mouth to esophagus and is going down into the stomach. Patients with GERD, that sphincter or the valve becomes loose. And once the valve is a little loose, if the intra-abdominal or stomach pressure rises, the stomach acid can regurgitate or come back into the esophagus. That leads to irritation of esophagus. So if there is recurrent episodes of reflux of stomach acid, that leads to irritation, inflammation, and ulceration in the lower esophagus, along with symptoms. That's called gastroesophageal reflux disease.
Very good. And speaking of those symptoms, can you talk a little bit about the symptoms that your patients most often experience?
So there is a big variety of symptoms that patients can present with. The commonest symptom is heartburn and regurgitation. So you feel water brash or sour taste in mouth, acid taste in mouth, or you get heartburn, meaning pain in the lower part of chest, burning sensation in lower part of chest. Those are the two common symptoms. But there are numerous other symptoms, including hacking cough, laryngitis, asthma, breathing difficulty, aspiration pneumonia, etc., that can all occur as a symptom of gastroesophageal reflux disease. Many of my patients even present with difficulty swallowing because acid reflux causes irritation and spasm in the esophagus. So the food does not go down as it normally would. All those symptoms are common with reflux disease. In fact, one of the commonest causes of asthma and chronic cough in this country is gastroesophageal reflux or GERD.
Ah, very good. Okay. And yeah, so I've been reading recently, especially adult onset asthmatic symptoms often are tied to GERD, correct?
That is correct, yes.
Okay, very good. So how do your patients tell you that they've managed, or tried to manage their symptoms? And what are your recommendations for managing their symptoms regarding GERD?
So there is multiple levels that we try to manage GERD. The symptom management, patients typically go try over-the-counter antacids, Tums or Rolaids or those kind of things, Gaviscon. And that helps immediately because there is acid in the esophagus. These are alkaline things. Once you swallow or Tums or suck on Tums, the alkali balances or neutralizes the gastric acid and leads to resolution of symptoms. But once that alkaline tablet goes into the stomach, it causes rebound hypersecretion of acid. So a few hours later, patients have even more acid production and more reflux. So in the long term, these drugs are not very effective. Also, they try to take over-the-counter acid suppression drugs like Pepcid, omeprazole, pantoprazole, etc. Again, those drugs work, but you need to fix the anatomical problem in the long run. So patients try to manage it themselves, but many times end up going to their primary care doctor. Our approach towards management of GERD is number one, to try and correct the problem. There is few issues here. One of the major issues is weight, obesity. Obesity has become an epidemic in our country. 2009 or 2008, I don't remember correctly, obesity took over tobacco smoking as number one preventable cause of death in the United States and has been ever since. Obesity leads to increased intra-abdominal pressure and increases the tendency to reflux. So it's the commonest cause of reflux in patients middle age and young adults. So we try to work on their weight side. We also try to treat symptoms with drugs called proton pump inhibitors, and with the view to eventually correcting the anatomical problem, which is the loose gastroesophageal valve. I'll stop here.
Very good. Thank you. So in talking about symptoms, one of the things that a lot of folks overlook is their inability to sleep when they talk about the problems that they're having with GERD. Many times they'll talk about that heartburn, a lot of the typical symptoms, but March is designated as National Sleep Awareness Month, and would love to spend a little bit of time on why GERD can impact sleep, how it does it, and obviously we'll get to what can be done in addition to some of the therapies you've already discussed in just a minute. But can you tell us a little bit about how GERD can impact sleep?
So GERD basically is reflux of gastric acid into the esophagus due to loose flap valve. So when the valve is loose, if you're sitting upright or standing up, the stomach is below the esophagus. So just as a result of gravity, you have an anti-reflux mechanism in place. If you were to bend over or cough or wear tight-fitting clothing, the intra-abdominal pressure tends to rise above the esophageal pressure, and then obviously gastric contents will regurgitate into the esophagus, including the acid, and reflux will take place. But at night, when you're lying flat, stomach and esophagus become single level. If you have a loose gastroesophageal valve, then the stomach contents tend to regurgitate into the esophagus. We tend to tell our patients Nocturnal reflux is very, very common, actually. These patients wake up middle of night coughing or with aspiration of acidic taste and aspiration of gastric juice, leading to coughing, asthma, spasms, and even aspiration pneumonias. So that is one of the major problems with reflux. We tend to tell our patients to, number one, try and eat more than 4 hours before going to bed. So once you eat, stomach starts secreting acid as a reflux phenomena to try and help digest the food. So you have a lot of acid and food in the stomach. Soon after eating, if you lie flat, that acid and food tends to regurgitate back into the esophagus. So you don't want to lie flat soon after eating. You want to stay upright for a few hours. Number two, we tend to use proton pump inhibitor, acid suppression drugs to help minimize the acid secretion. And those drugs are very effective in preventing reflux in most of our patients. But after a while, they tend to, reflux increases, the valve become more loose, and those tend to become less effective. Also, the drugs, proton pump inhibitors, have long-term side effects. So short-term, these drugs are very safe. Long-term, there is current literature suggesting there is risk of dementia, kidney damage, bone marrow, bone thinning, and some other problems, including infections, gastroenteritis, etc., because stomach acid is our first defense against ingested bacteria. So all those things can occur. That's why long-term use of proton pump inhibitors is going out of fashion, and there's a trend towards mechanically correcting the defect, the anatomic defect, the loose valve.
Very good, thank you. So we've talked about managing GERD. If GERD goes unmanaged, what can that lead to?
Good question. I just wanted to go back, remind you about the sleep, because it's sleep. And many of my patients tell me they are sitting upright at night because when they lie flat, they start coughing, they start getting wheezing. So they sit sleeping upright, or they use 2 or 3 pillows so they're half upright to try and manage those symptoms. And it works sitting upright, but as you can imagine, that's not a comfortable or proper sleep. Moving on to your next question.
Just as far as managing GERD, what we've talked about that. What can unmanaged GERD lead to if patients are not receiving treatment?
So the long-term complications of GERD are many. The more common ones are deep ulcers that can lead to stricture or narrowing of the esophagus, and deep ulcers that can cause symptoms of severe pain, bleeding, etc. But the most dreaded complication of long-term reflux is carcinoma of the esophagus or esophageal cancer. Fortunately, carcinoma esophagus goes through different stages. So you don't get reflux and then straight away jumping on to cancer. With chronic acid reflux, chemical irritation of the esophagus, the lining of esophagus changes. It becomes more like stomach or small bowel lining. It's called intestinal metaplasia or Barrett's esophagus. So about 20%, it's estimated that 20% of adult US population have gastroesophageal reflux disease, and 4 to 5% of those patients go on to develop Barrett's esophagus, meaning they develop a risk for progressing to carcinoma of esophagus. Cancer of esophagus is one of the most dreaded cancers known to mankind. Very, very high mortality, and unfortunately, there's no good treatment unless it's caught in early stages. So that's why it's important to get the reflux checked, look for Barrett's esophagus. When we do any endoscopy, we look for Barrett's, and then if we find Barrett's, we treat it. Then we try to prevent future reflux by anatomically correcting the valve.
Excellent. I'm going to ask you 2 more questions, and then we're going to turn it over to Karen. She's letting me know that we already have questions coming in, so thanks everybody for submitting those. We'll get to them shortly. Can you tell us about the options that are available to treat GERD beyond medicine?
So, as I mentioned, weight reduction is one option. Medication is another. Long-term medicine use. GERD is a problem, a chronic problem. Once you develop reflux, it does not go away with medication. If you have a loose valve, it persists, and with age, unfortunately, it tends to become more loose. So the option is to go in and tighten the valve. In the old days, this used to be done by surgeons. They would open up the chest. It was a major operation called Nissen fundoplication. They would open up the chest, go in, tighten the junction between esophagus and stomach. The procedure is called Nissen fundoplication. That went out of fashion, was quite a morbid procedure. Came laparoscopic fundoplication, where they make keyholes in the just below the rib cage in the stomach, go in and tighten the junction. And then more recently, in 2007, 2008, we had the FDA approve transendoscopic incisionless fundoplication, or TIF. I was fortunate to be one of the first in country to train in TIF procedure. I started doing it in 2009, trained very early. Transendoscopic incisionless fundoplication has results similar to the surgical fundoplication, but there's no incision involved, so there's no risk of infection, bleeding, wound problems, etc. And there's no scarring outside. So you can always redo or do procedures again as well if need be.
Very good. Thank you. So can you tell us a little bit about the TIF procedure, how it works? It's just profile it for us.
So TIF procedure, I should have drawn a diagram, but basically the junction between esophagus and stomach is loose. TIF is a special device, mechanical device, that we load on an upper endoscope. So when we do an endoscopy, we retrovert the scope or look backwards at the junction, and we can see the loose valve. Then the TIF machine is loaded onto the endoscope. It's a hollow tube with suturing mechanism in it. We go in and basically suture the junction between esophagus and stomach, creating a nice donut-shaped valve that creates an angle, good angle between esophagus, stomach, and tightens the junction between esophagus and stomach. It's similar to what the surgeons do in Nissen fundoplication. It's incisionless, basically endoscopic fundoplication, we call it. So it tightens the junction and creates a nice round valve in the lower esophagus, stomach junction area, thus preventing reflux.
Right,
about 45 minutes procedure, 30 to 45 minutes. We put about 30 sutures around about 240-degree valve created.
Very good. Thank you very much. Karen, I'm going to shoot it over to you for a minute to go ahead and ask some of the questions that folks are sending in.
Thank you, Wendy, and thank you, Dr. Ayub, for being here tonight. We had a lot of questions to get to. First question is from Jane, and she's asking, why does asthma cause GERD? And I think you touched on this briefly at the beginning.
Okay, so in our opinion, happens is patients who have tendency to asthma, there is smooth muscle in their trachea, bronchi, bronchioles, which are the respiratory pathways, respiratory tubes. That muscle is sensitive and it can go into spasm very easily. They have sensitive, smooth muscle fibers. When you aspirate a little bit of acid, it irritates your respiratory tract, and that leads to spasm of those bronchioles, bronchi. That makes it difficult for them to breathe in and out, especially breathe out. And that leads to asthma, what we call asthma or wheezing, difficulty with breathing. And so basic mechanism is acid or gastric secretions aspirated into the larynx and trachea as a result of reflux.
And we do have a question, thank you, from Denise. She was asking if Barrett's esophagus can go away, and I think you just explained that earlier with treatment options for Barrett's.
Good question. So Barrett's esophagus, and I treat a lot of Barrett's. I had a big NIH grant when I was in Seattle. I was part of the Seattle Barrett's Esophagus Center, which is a world famous center. If you treat Barrett's, the purpose is to try and prevent progression of Barrett's or abnormal epithelium to cancer. Barrett's goes away. But if the reflux persists, if you don't treat reflux, what we found is that within a year to 2 years, Barrett's come back. So it's a two-step procedure. First, you need to go and treat Barrett's esophagus, and then you need to treat acid reflux problem, anatomically fix the valve so Barrett's does not come back, if that makes sense. Otherwise, Barrett's can come back again, and typically it does.
Thank you for that. Gloria has a question. She said she's been taking PPIs for over 2 years now, and she still has acid reflux.
So about 10% of my patients have the same situation as Gloria. The acid reflux medication are not effective. They're only effective in 85 to 90% of patients. 10% of patients not very effective. They continue to have reflux symptoms. Another 5 to 7% of patients have side effects. Diarrhea, nausea, headaches, etc. are the common side effects from those drugs. And then there can be the long-term complications as well. So that's why we recommend trying to fix the problem rather than taking long-term medication. If she is not responding to those medicines, she needs an upper endoscopy, evaluation by pH testing if needed, and then get the problem fixed.
Thank you for that. And Connor was asking, what causes a reflux valve to quit working?
Good question. What causes a valve to become loose? Unfortunately, with age, valve is the lower esophageal sphincter. As you age, all the sphincters have tendency to become loose. The gastroesophageal valve, I think, has the higher tendency to become loose. If you have obesity or other coexisting problems, that can also increase the pressure, make the valve work harder, and valve tends to become loose. There is many other food items that can affect the valve, especially smoking causes the valve to become loose, the gastroesophageal valve. Alcohol, chocolate, desserts, all these items can make the valve loose. So that's temporary, but with age, some people have genetic tendency to develop reflux, have a loose valve. And then on top of that, these environmental factors, diet, smoking, other habits that I mentioned can add to the problem.
For that. And I have one last question before I will bring it back to Wendy. This is from Jason. He's asking, can you explain at what point would someone need surgery versus staying on medication?
Good question. I think it's a question that really has to be individualized. So just to give you a few examples or scenarios, if I have a young 20-year-old patient, I don't want him to take proton pump inhibitors for next 70, 80 years of his life. There's high likelihood that he will develop long-term complications of those medications and can develop Barrett esophagus despite taking the medicine. So I would like to treat that patient either surgery or endoscopic fundoplication, depending on his anatomy. If I have an 85-year-old patient with heart disease, asthma, COPD, or lung disease, I think that I would treat that patient with medication, number one. Number two is depends on the quality of life and how effective the proton pump inhibitors are in a given patient. If a patient is doing well with alternate day proton pump inhibitor, has no major symptoms, I think I can wait on that patient. But patients who are symptomatic, keep getting reflux, complications, I like to treat them. Excuse me. Any patient with Barrett's esophagus or other complications, asthma, we like to treat the anatomic problem.
Thank you for that. And Wendy, back to you.
All right. Thanks, Karen. Well, Dr. Ayub, I hope we're not wearing you out. Thank you very much for everything that you're giving us as far as information goes. I'm curious to know what commonly draws your patients to TIF. What are the attributes that they find most attractive?
So over the past 10 to 15 years, there has been a paradigm shift, especially in last 10 years. A big study was published in JAMA, one of the big medical journals, following the patients who are taking proton pump inhibitor for years and years. And they found that the incidence of dementia in patients taking proton pump inhibitors was higher, more than twice as likely to develop dementia as patients who were not taking proton pump inhibitors. Another big study came out looking at the kidney impact on kidney function. And these patients tend to develop chronic kidney disease much more often than patients who are not on long-term proton pump inhibitors. We already knew that gastric acid is the main defense against foodborne infections, bacteria or viruses. when you eliminate gastric acids, you're much more likely to develop gastroenteritis. So for example, a person with reflux disease, if they were to go to Cancun, Mexico on a vacation and they continue taking their proton pump inhibitor, more than 10 times as likely as a person who is not taking proton pump inhibitor to develop diarrhea or gastroenteritis. And we know that there is problem with bone thinning and other issues because it does affect vitamin D absorption. Vitamin D requires stomach acid to get absorbed properly. So patients who have stomach acid eradicated by proton pump inhibitor tend to develop vitamin D deficiency over a long period of time and develop thinning of bone and bone fractures, which is a common cause of death in the elderly men and women. Hip fractures, spine fractures, as you know.
Very good. Thank you. So can you also talk a little bit about patients who have been diagnosed with, a loose lower esophageal sphincter? They have GERD. There's often a condition called hiatal hernia that tends to accompany that diagnosis. Can you tell me a little bit about what that correlation is?
So hiatal hernia is defined as herniation of stomach into the chest. So when part of the stomach is above the diaphragm, we call it hiatal hernia. This is not uncommon. As I mentioned, reflux occurs in about 20% of adult population. Many of these patients, a significant majority of these patients have hiatal hernia as well. Hiatal hernia can be small, medium, or large. If it's a small hiatal hernia, it does not bother us too much. We can still do TIF. But if it's a larger hernia, then it affects our choice of treatment. If the hiatal hernia size is more than 2 centimeters, we tend to do a procedure called combined TIF. So patient has hiatal hernia repaired by surgeon, and at the same time, we go in and do transendoscopic fundoplication, incisionless fundoplication. And that is a very common and successful procedure in patients with a medium or large hiatal hernia.
Excellent. And do you and the surgeon tend to partner often? Are those, what would you say the number of cases looks like when you do a TIF versus a combined TIF?
So I think that right off the top of my head, about 70%, 60 to 70% of my patients are combined TIF. About 30% are TIF alone.
Okay, very good. Thank you. So can we talk a little bit just about recovery when a patient has a TIF procedure, and actually maybe before we get there, we talk about what leads up, what a patient experiences as they go through their prep and their preoperative steps versus postoperatively. So
there's a few steps involved here actually for this procedure. Number one, I like them to lose weight. The American Thoracic Society recommends the BMI ideally be less than 30. Between 30 and 35 is a gray area, but we like it ideally to be BMI below 30. So weight loss is very, very important. And believe it or not, many patients, if they are able to lose weight, their GERD symptoms improve a lot and they might not even need surgery. Number two, we like to do workup on these patients. So first of all, we do what we call Bravo pH monitoring, where we go in and place a small probe in the esophagus, 6 centimeters above the junction with stomach. And this probe measures the acidity of esophagus or pH of the esophagus. Esophagus pH should not go down below 4. Gastric pH is between 2 and 4. So we see how often the pH drop below 4 in 48-hour period. We can do it for 48 hours or 4 days, 96 hours. So the Bravo is required unless patient has Barrett's. If a patient has Barrett's esophagus, then we do not do Bravo because that is a proof that they have severe reflux already. If patient has difficulty swallowing or dysphagia, then we also do motility study of esophagus. We call it esophageal manometry to measure the contractions of esophagus, see how well it contracts. Because if contraction is not good and we tighten the junction between esophagus and stomach, patient will not be able to swallow. That said, those are the main preparatory steps we do before proceeding. With many patients, if they have an HMO or private insurance, not Medicare, then we require prior authorization from the insurance carrier as well. Medicare and Medicaid does not require prior authorization.
Okay, yeah. I am seeing that we have a lot more questions, Karen. I'm going to turn it back over to you and go ahead and have you fire away.
Thank you. We have a lot of great questions tonight, so I hope I can get to all of them. Paul, it's really kind of a statement, but I think he just wants some clarity. He said he was taking amisoprole and it caused a vitamin B12 deficiency that led to some blood clots in his legs and lungs. And I think he's just looking on more clarification on I guess the side effects of those PPIs.
So he was taking omeprazole. Omeprazole, basically what it does is it almost eliminates gastric acid for 24 hours. So if you're taking it every day, you have very little stomach acid. Stomach acid is needed to digest and absorb fat-soluble vitamins. Those are vitamin A, D, E, and K. Vitamin K basically works on clotting factors and can cause thinning of the blood. Vitamin A and D are different. Vitamin D is basically involved with the calcium phosphorus metabolism and bone structure, bone and teeth. So B12 is, to my knowledge, not affected by omeprazole B12 absorption and would be unrelated. But vitamin K, if you have vitamin K deficiency, you can develop bleeding tendency, but not clotting. So I think there is some confusion here.
So can I also ask on that, if you are taking a medicine that eliminates all of your stomach acid, does that make you prone to foodborne illness?
Yes. As I mentioned before, they're very prone to gastroenteritis. If they were to go to Mexico, basically gastric flu or gastroenteritis, diarrhea are much more common, 10 times more likely if you are on proton pump inhibitor than if you're not taking proton pump inhibitor.
Okay, thank you.
Rochelle is asking if TIF will help someone with acid and bile reflux.
Good question. So I think Michelle has come up with a beautiful question. There is a lot of controversy in medical literature. Many experts think that gastroesophageal reflux disease is due to gastric acid. But there is some carcinogens in stomach contents, including bile, that when it comes to esophagus, it can be carcinogenic in some animal models, including guinea pigs. So we think that bile reflux can be a problem as well. If you eliminate gastric acid and you have loose valve, then you're still getting bile reflux and you're still getting regurgitation of stomach contents into the esophagus. TIF goes in and tightens the GE junction. So it prevents all reflux, basically acid reflux, bile reflux, and reflux of other gastric content, be it pepsin or food content or whatever. So TIF does work on both. Omeprazole or proton pump inhibitor do not eliminate bile reflux, only eliminates acid.
Excellent. We have a two-part question from Janetta. Her first question is, would having EDS cause GERD to be more likely? And EDS is Ehlers-Danlos syndrome, which is a hereditary disorder of connective tissues.
Yes, we think that all these connective tissue disorders, especially Ehlers-Danlos syndrome, where the ligaments are very loose, all the tissues lax, would increase the tendency for reflux. On the other hand, Ehlers-Danlos patients are typically slim and tall, slim and lanky, so that might have some preventive effect. But no, their valves tend to be loose.
And then her next question was, what do you think about, I guess, the LINX procedure and how does that compare to the TIF procedure?
So these are two different procedures. Links is where surgeon goes in. It's a procedure where surgeon goes in with a laparoscope, makes a keyhole, and puts a little bracelet around the distal esophagus. Only this bracelet is a magnetic bracelet. It's a bracelet made of magnets. So that way, that magnetic bracelet tightens the lower esophageal sphincter. Basically works beautifully if patient does not have motility problem, that it works very, very well. Patient's reflux is pretty much cured for a while. The problem we had is LINX is relatively new procedure. These magnets after a while, because of constant pressure, cause ischemia due to compression of the tissue. Human tissue is very susceptible to ischemia. All the viable tissue needs blood supply, needs oxygen brought in by red blood cells. So this causes over long period of time pressure necrosis, and we see erosions or ulcers in lower esophagus. And we have seen many cases where they eventually, part of the magnetic bead or bracelet erodes into the esophagus, and then we have to take them out. I think that LINX came in, it was a good procedure, but now after 5 years, we are seeing more and more complications. And the surgeons I knew who were doing LINX have now partnered with me to start doing combined TIF. And LINX is going out of fashion. But it is a good procedure. There is this risk of erosions and ulceration and erosion of the beads, magnetic bead into the esophagus.
We have one last question from Yasmin, and she's wondering, does GERD affect the colon?
Does GERD affect the colon? To my knowledge, GERD in and of itself does not affect the colon. But the way we manage GERD can affect colon, especially proton pump inhibitors and other drugs can have effects. Infection like C. diff is much more common if you're taking acid suppression or proton pump inhibitors, things like that. But directly, GERD only affects the esophagus and the lungs and supraesophageal structures, larynx, etc.
Wendy, back to you.
All right, thank you. Just learned something about the way that GERD can affect other parts of the body. Hadn't really thought about that, and just the treatments that you take and how it impacts everything. Thanks for that. So can you talk about, Dr. Ayub, what your patients do to prepare for their TIF procedure, how they feel afterward, and how they manage their post-op diet, what you recommend, and kind of when they can resume normal activity?
Good question. So first, I wanted to go back to your comment about GERD affecting other organs. One of my major referral source is respiratory physicians, pulmonologists. They see patients with asthma. They see patients with cough. They see patients with recurrent aspiration pneumonias, and they tell them, you have reflux, go to Ayub, get an endoscopy done. That's how I get a lot of my referrals, GERD patients. So lungs and larynx, etc., are really targeted by GERD and affected by reflux. Moving on to the care of these patients, pre-op, I mentioned the testing. I mentioned that we want them to lose weight, be fit, BMI less than 30, ideally, before we do TIF. Once we perform fundoplication, we have tightened the junction between esophagus and stomach. The anatomy has altered. So these patients need to adjust to that new anatomy. It takes a little while. We start them on full liquid diet and keep them on liquids for a few days to a few weeks. Some surgeons want them on full liquid for a few weeks. I try soft diet after a few days. So they have to stay on full liquids after TIF for up to a week or so. Full liquids is not too bad. I tell them it includes many things, including soups like lobster bisque. It includes ice cream, jello, protein shakes, fruit smoothies, etc. So all those sort of things, they can have yogurt. They stay on this liquid diet for a week as their esophagus learns the new mechanism where esophagus has to contract more properly and harder to push the food into the stomach. Then they go on to soft diet, and they can stay on soft diet for a few weeks before going on to regular diet. They also need to be careful. Initially, there is some chest pain, there is new suturing, so we don't want them to lift heavy weights or do any heavy exercise walking is okay, but lifting 50 pounds or more weight can increase intra-abdominal pressure and put tension on the sutures and can disrupt the construction we have done there, the valve that we have created. So they have to basically take light duty so far as weight lifting is concerned. They have to stay on liquid diet and then soft diet. They do stay on proton pump inhibitor for first. My patients, I like to keep them on proton pump inhibitor for 2 months before stopping. But that would be the typical course. Patients stay in the hospital overnight and go home the next day typically. Many patients have chest pain, some discomfort. It's mild, much less than if they have surgical fundoplication using the laparoscopic technique or robotic technique. They have a lot more pain that way. So they recover much quicker because it's incisionless. But because we put sutures between the esophagus stomach junction, there is some discomfort, chest pain in many of my patients. But next day they go home.
Okay, thank you. So circling back really quickly, I want to make sure I don't miss this. You have a busy month in your specialty, right? It's colorectal cancer awareness month. And as we all know, the pandemic has put a pause on elective procedures. It's been a big challenge being a patient, being a provider of care. And we just appreciate so much everything that you have done to continue to care for the community. With it also being Barrett's Esophagus Awareness Month, do you have any thoughts you want to offer on how people can see if they are maybe somebody who might be predisposed to have this, what they can do to be screened, et cetera?
Yes. So first of all, you mentioned colorectal cancer month. So if you don't mind, I'll just mention very quickly that our group, Southwest Gastroenterology, I'm very proud to say that we were the first group in state of Illinois to offer GI Genius, which is an artificial intelligence detection system for colon polyps. So when we do colonoscopy, we have the added bonus of GI Genius with our endoscopes in our surgery center in Oakland. We have been pioneers in many other technologies coming to this state as well. Again, I was one of the first in the country, but really one of the first in state of Illinois to offer TIF procedure. Talking about the reflux and Barrett's esophagus awareness month, carcinoma esophagus, as I already mentioned, is a very lethal cancer. It's the worst cancer known to mankind. The 5-year survival, if at the time of diagnosis cancer is past stage 1, is less than 5%. 95% are dead within 5 years. It's worse than pancreatic cancer and other cancers. So we basically ask patients if they have symptoms of heartburn more than twice a week. That means they have reflux. If they have cough, unexplained cough, wheezing, asthma, unexplained or recurrent respiratory infections, then they have reflux. And if they are overweight, obese, more than likely they'll have reflux. And those patients, any of the reflux symptoms, they should seek medical advice. They should see their primary care doctor or a gastroenterologist. And in most cases will end up getting an endoscopy to look for Barrett's esophagus. Especially if you have reflux more than 5 years, the current American Society of Gastrointestinal Endoscopy recommend that you should undergo a screening upper endoscopy to look for Barrett's esophagus. We will biopsy the lower esophagus because Barrett's esophagus is a precancerous condition. So we want to diagnose it and treat it appropriately. Other than that, the old guidelines recommended looking for Barrett's only in white men over age 50. But now those guidelines have changed. It's basically, we feel that reflux and Barrett's does not have any gender preference. Men and women are affected. All races are affected. So it affects all races and gender and should be I think we need to be vigilant. If you have symptoms of this disease, it can lead to a lethal cancer, but also many other complications, including asthma, pneumonias, stricture of esophagus that can be dangerous, etc. So it needs to be treated, the reflux disease and Barrett.
And so what is your recommendation to a patient who is just seen maybe a family practice doctor all their lives. They haven't really sought out any treatment from a specialist before, but they're starting to have those symptoms. Who is it best for them to communicate with on that to get the help that they need?
I think they need to go to a gastroenterologist. If they are seeing their primary care, they might mention to their primary care that, hey, do I need an endoscopy? Should I be seeing a gastroenterologist? My feeling is that after 2 months of proton pump inhibitor, you should stop. If your recurrent symptoms not doing well, the first line treatment, weight reduction, diet adjustment, not eating fatty meals, quit smoking, etc., have not worked, you need to see a gastroenterologist and get an endoscopy done.
Thank you. So just in talking about the TIF procedure, how do patients say that they are enjoying life after TIF? What does life look like GERD-free?
So many of my patients are able to enjoy the meals they could not take before, even despite proton pump inhibitor treatment, including pizzas, spicy meals, fatty meals, etc. They are able to eat that. That does not mean that they should put on weight. I think that they must control weight, otherwise TIF can become loose as well. So obesity is a problem and remains a problem. But they are able to have better quality of life. They are able to eat all sorts of food and enjoy it without getting up at night, sitting up, getting cough or asthma or spasms at night, etc. And I think that overall, there is a huge change in their food quality and their quality of life. They're able to eat all sorts of meals without provoking reflux symptoms.
Excellent. Do you get any, when your patients come back in, do you get any comments from friends or family that say how it's impacted them when their loved one has had TIF?
The loved ones tell me that they are able to sleep flat at night. They are not waking me up. They're not sitting up coughing in the middle of night or wheezing the middle of night, and they sleep through the night now. So the night sleep improves a lot as well. And obviously they're able to go out and enjoy Italian food or whatever have you, all sorts of food that they like, that they could not do before.
That's interesting. I don't think I'd really thought about the fact that just because a patient is experiencing symptoms doesn't mean that their loved one isn't experiencing the impact of some of those things as well. The sleep thing for sure. Gosh, here I thought my husband snoring was, the only impact that there was. Maybe those who wake up coughing are doing that too. So we're coming to the end of our session. What I would like to ask is if you have any parting thoughts that you'd like to offer to those who are out there, who are suffering, who are weighing their options. What, as far as, do I go in and see somebody? Do I go down to the store and see if I can manage my symptoms with another type of medicine? What are your thoughts there?
So if a person has heartburn, reflux symptoms that I mentioned before, including cough, asthma, regurgitation of food, etc., then, and if it occurs more than once a week, I think that they should seek medical advice, see their primary care doctor. If they're overweight, I think weight reduction is the first step. Any doctor will tell you need to lose weight. If they're smokers, they need to quit smoking, but they should also get an endoscopy done. Smokers and overweight people, big studies have shown, are much more likely to progress to carcinoma esophagus, to develop Barrett's esophagus, and progress to carcinoma esophagus than non-smokers and non-obese people. So weight reduction, smoking cessation is something you can do yourself. Not easy to do, mind you, but you can do yourself. It's in your hand. Then if symptoms don't improve and you've seen a primary care, then you need to seek a gastroenterologist and get an endoscopy done. And at time of endoscopy, we will look for reflux, we will measure the hiatal hernia, we will evaluate your valve and decide what is the best treatment option, whether just the lifestyle changes, including quitting smoking, losing weight, is sufficient, whether they need to go on to transendoscopic fundoplication or whether they need combined TIF. So based on their presentation, based on the anatomical abnormality, we make a decision afterward. We sit with the patient and talk to them and decide what is best in a particular setting, in a particular patient, and then try to offer that treatment. It's a decision that we make with the patient and their loved ones. It's a long-term commitment.
Yes, and there's so much thought now that we see that goes into these decisions. Even when patients are out of the office, they're viewing programs like this, which is why we're so appreciative of the fact that you come in and you give of your time to educate on all options and what they each offer. So thank you very much for that. I want to wrap up tonight by making sure that everyone out there knows about the GERD Help app for patients who are looking at different options, looking at their symptoms, et cetera. It's an excellent resource for you to go ahead, do a little more research, hear from physicians on videos that we have available, as well as different articles, and even being able to do a journal to help document the symptoms that you're experiencing, the times of day, et cetera. It's an excellent resource and will help you be armed with even more information to take into your doctors as you seek treatment. Also, for physicians in your area, first of all, Dr. Ayub, I want to make sure that everyone has seen your contact information on the screen. If you want to share with everybody, I know you talked about your schedule earlier, being in New Lenox on Mondays and Tuesdays, I believe. If you want to lay out the rest of your week and where you are, that would be great. Also, how patients can get in touch with you online.
Okay. So I am in New Lenox area, Silver Cross Hospital, every Monday, Tuesday. I tend to go to Good Samaritan Hospital in Downers Grove on Wednesdays, and also go to Christ Hospital Wednesday afternoon, which is in Oak Lawn. Thursday, I'm in Joliet and Silver Cross. And then Friday, I go back to Oak Lawn Endoscopy Center, where I do skin and colonoscopies and other common procedures. And then I go to Christ Hospital Friday afternoon. Twice a month, I tend to go to Carl Hospital in Urbana-Champaign, and I offer all the specialized treatments there. TIF is coming there soon. We are working on it, and hopefully we'll have endoscopic treatment for reflux there, but I offer a lot of other options there too. So that's the typical schedule.
Terrific. Wow. Well, thank you very much. I'm so pleased that you could join us this evening. For those of you who are not in the greater Chicago area and are looking for a TIF expert near you, go to gerdhelp.com. We have a physician locator where you can enter in your zip code and find TIF trained specialists in your area. Dr. Ayub, thanks again so much for being with us, and wishing you a wonderful spring right around the corner, right? And we hope that you'll join us again very soon. Everybody, have a great evening.
Thank you, Wendy. Thank you, Karen, and wish you a nice spring as well. Chicagoland, you can never trust when you get the spring, but I wish you happy spring.
Thank you. Good night, everyone.
Good night. Bye-bye.